Okay, good morning, class. Um, Today we're going to be talking about the gross anatomy of the shoulder joint. Um, the shoulder joint, also known as the glenohumeral joint, is actually a synovial ball and socket joint that connects the upper limb to the trunk. It is formed by the articulation of uh, the head of the humerus and the glenoid cavity of the scapula. It's actually the most mobile joint in the body, of course, that allow movement in different multiple plane. Okay, um, you know, but then this highly mobility actually comes at the expense of stability, of course, making it very prone to dislocation. Now, the shoulder joint, if we want to classify it, then we will say that the shoulder joint is a synovial joint, a ball and socket joint, and a multi-axial joint. It allows movement in sagittal, coronal, and even in transverse plane. And what are the articulating surfaces? The head of the humerus, okay, which is very large, hemispherical, and then covered with hyaline cartilage. It faces medially, superiorly, and then posteriorly. Then we have the glenoid cavity, of course, of the scapula, which is very shallow and pear-shaped, which faces laterally and slightly anteriorly. Well, this glenoid cavity is much more smaller than the humeral head, okay, contributing to instability. Now, there is also something called the glenoid labrum. The glenoid labrum is actually a fibrocartilaginous rim that is attached to the margin of the glenoid cavity, which helps to deepen the socket and increase stability. It actually also serves as an attachment for the joint capsule and, of course, and the long head of the bicep brachii. Now, what about the joint capsule of the glenohumeral joint? The joint capsule is enclosed by a thin, loose, fibrous capsule, and of course, it has its attachment. Medially, it attaches at the margin of the glenoid cavity outside of the labrum. Laterally, attaches to the anatomical neck of the humerus, and then here the important feature here is that the capsule is weakest inferiorly and of course forms a loose fold. Now, why this happens is that it allows for a wide range of abduction, ABD, but makes the joint susceptible to anterior inferior dislocation. Now, what about the synovial membrane? The inner surface of the capsule is lined by a synovial membrane that secretes synovial fluid for, of course, you know what synovial fluid does for lubrication. It extends into the intertubercular grooves and forms a sheet around the tendon of the humerus of the bicep brachii. Okay. Okay. So let's talk about the ligament of the shoulder joint. The glenohumeral ligament is one very strong. Uh, Includes superior, middle, um, and inferior bands. Yes, they are actually thickenings of the anterior capsule and reinforced joint anteriorly. Now, the inferior glenohumeral ligament is actually the most important in preventing dislocation. Then there's another ligament called the coracohumeral ligament. The coracohumeral ligament extends from the coracoid process to the greater tubercle of the humerus, and of course, it strengthens the superior part of the capsule and supports the weight of the limb. Then there's another ligament called the transverse humeral ligament. Of course, that one bridges the intertubercular groove and, of course, holds the tendon of the long head of the bicep in place. Then there's another one called the coracoacromial ligament. The coracoacromial ligament forms the superior no, it forms the coracoacromial arc, which of course, you know, prevents superior displacement of the humeral head. And of course, all this also helps with, they all help in stabilization with muscle. Okay, some of the muscles that helps in stabilization, or what we are going to call muscular stabilization, is the rotator cuff muscle. But of course, this include this, that's the sixth muscle, the supraspinatus, the infraspinatus, the teres minor muscle, and of course the subscapularis muscle. And of course, they surround the joint, fuse with the capsule, and stabilize the humeral head in the glenoid cavity. There are other supporting muscles though. For example, the deltoid muscle is the main abductor ABD of the arm. The long head of the bicep brachii also provides additional stabilization superiorly. Now, being a joint, it has what we call bursa. Okay, bursa is like sac filled spaces. Okay, that help lubricate the joint, and we have one called the subacromial bursa. Some textbook will call it subdeltoid bursa because it's located between the supraspinatus tendon and the acromion. Of course, it reduces friction during abduction. Okay, then we have another bursa called the subscapular bursa, which is located between the subscapularis tendon and the scapula. Yeah, it communicates with the joint cavity. Okay, now the glenohumeral joint gets its blood supply from the anterior circumflex humeral artery, the posterior circumflex humeral artery, the subscapular artery, and this no the suprascapular artery, yeah, and the subscapular artery, and of course these vessels, blood vessels, contribute to the scapula anastomosis. And this joint gets its nerve supply from the axillary nerve, the suprascapular nerve, and the lateral pectoral nerve. The axillary nerve is the most important, actually, uh, if you ask me clinically. Okay. Mm, what are the movements of the shoulder joint? The shoulder joint allow for quite a number of movements, and because of that, its stability was compromised. It allows for flexion, extension, abduction, adduction, ADD, medial rotation, lateral rotation, and then circumduction. Also allow for circumduction. Uh, there's also something I didn't mention, that is the relationship, with structures are uh, structures around. Permit me, so tired, very early in the morning. Um, well, superiorly, this shoulder joint is related to the coracoacromial arc and the deltoid muscle, inferiorly to the axillary nerve and the surgical neck of the humerus, anteriorly with the subscapularis muscle and coracal process, and posteriorly the infraspinatus and the teres minor muscle. Okay, well, the clinical application of this is in shoulder dislocation, and it is important to know that most commonly occur in the anterior inferior direction due to weakness of the inferior capsule, and of course when this happens it might actually injure the axillary nerve. Then we also have what we call the rotator cuff tear, which is most commonly affects the supraspinatus tendon, and of course when it happens, it might lead to difficulty in initiating abduction, that's the ABD. Then there's also something called the frozen shoulder, which some people call the adhesive capsulitis. Okay, this one is actually characterized by stiffness and restricted movement due to thickening of the capsule. Okay, so, and then we also have other ones like the infringement syndrome, which this one occur when the supraspinatus tendon is compressed under the acromion. So the shoulder joint is very highly mobile synovial ball and socket joint with actually minimal bony stability, and of course its stability depends largely on the muscular support, especially the the rotator cuff, and of course this allows a very wide range of movement, like I said, but it actually makes that joint highly susceptible to injury. So I hope this helped. Maybe in our next class we'll talk about the the the, the forearm proper. Then after the forearm we'll talk about the elbow joint. All right. Good morning, everyone. Thank you.